Okay, we'll start. I'm opening the PPT, the first slide. Okay, so we titled it Clinical Significance of Syphilis, Diagnosis and Management. That's interesting. I'm sure if you will go back, if you worked in the lab at times, you will have people coming in for this test, very common test, VDRL, especially the guys who are joining a new job or they're going abroad, pregnant ladies. This is one of the most basic tests on the panel, right? Besides the CBC and sugar and so on. So we asked the question, what is syphilis? So syphilis is a sexually transmitted disease caused by the spirochete Treponema pallidum, previously known as the great imitator. This disease can have numerous and complex manifestations. Family physicians should understand its presentations, stage-specific diagnostic testing, appropriate antibiotic treatments, because missed or inappropriately treated syphilis can result in devastating cardiovascular and neurological diseases as well as congenital syphilis. So it's because this is one disease that goes away without treatment in the beginning, right? Some signs and symptoms are there, and if it's missed. Okay, good afternoon, Shobha. We've just started, all right? We are on the first slide, and we said we were asking what is syphilis, what causes syphilis, and I said that it is the organism called Treponema pallidum. It's a spirochete, and we deal with this very often. And like I said, it sometimes goes off untreated and then comes back again very, very virulently. All right. So over here you've got ulcers. Generally appears after 21 days of sexual contact with the infected person. So it is a sexually contracted disease, and like I told them that this test is ordered on people, on ladies who are pregnant, on people who are going abroad, people joining new jobs. This is one of the regular tests besides the other parameters. So syphilis, we said, is sexually transmitted disease with varied and often subtle clinical manifestations. Primary syphilis typically presents as a solitary, painless chancre. Chancre is something like a little boil, whereas secondary syphilis can have a wide variety of symptoms, especially with fever, lymphadenopathy, rash, and genital and perineal condom, like later. Okay? Latent and late syphilis. In latent syphilis, all clinical manifestations subside and infection is apparently only on serological testing. Late or tertiary syphilis can manifest years after the infection as comatose disease, cardiovascular disease, or central nervous system involvement. Neurosyphilis can develop in any stage of syphilis. So this is what it is. As chancre appears, it disappears, and then it comes back again after some years. And like I said, you're doing serological testing. Usually, like I said, doctors ask for the blood test, and usually we do serum testing with the so-called Treponema antigen. All right. Diagnosis of syphilis may involve dark field microscopy, which is very good, of skin lesions, but most often requires screening with non-treponemal test and confirmation with a treponemal specific test. So you have a non-treponema test and a very, very specific confirmation. And I have a picture for dark field microscopy below. So you have to have a microscope that has the attachment for the same, and you can see the spirochete-like structures in the fluid. Treatment at parenterally administered penicillin G is considered first-line therapy of all stages of syphilis. Alternative regimens of non-pregnant patients with no evidence of central nervous system involvement include doxycycline, tetracycline, ceftriaxone, and azithromycin. In pregnant women and patients with neurosyphilis, which has affected the nerves, penicillin remains the only effective treatment option. If these patients are allergic to penicillin, this is what is tested, the test was given, penicillin, desensitization is required before treatment is initiated. So here, before the penicillin dose is given, a little bit is injected in the sink and to see if there's any reaction to this penicillin, otherwise it is a problem. So once the diagnosis of syphilis is confirmed, quantitative non-treponemal test titers should be obtained. These titers should decline fourfold within 6 months after treatment of primary or secondary syphilis and within 12 to 24 months after treatment of latent or late syphilis. Serial cerebrospinal fluid examinations are necessary to ensure adequate treatment of neurosyphilis if it's affecting the brain, that is. So even when we are let's say we are doing the VDRL test in the laboratory, we are taking the patient's serum after decomplementing it and adding the so-called antigen. Let us say you get a roughness. Usually what we like to do, we like to see this in the, spread a little under the cover slide and see it under the microscope. So if it is rough, then what you would have to do, and the doctor will expect you to do a serial dilution of the serum and start all over again, 1 and 2, 4, 8, and then you add the antigen and you see, you get the highest titer giving you visible. It's not agglutination, it's flocculation. This is a flocculation-based test. So the higher the titer, that means the disease has progressed in a very, very big fashion. Lower the titer, all right, usually anything up to 4, 1 and 4 is okay. Anything above 1 and 4 is considered diagnostic. So your doctor will ask you what is the titer, and depending on the titer, the treatment has to start. Now there are other tests than the VDRL tests which we can also do. So let's take a look at it. So neurosyphilis, of course, meaning it is to deal with the nerves. So neurosyphilis at any stage of syphilis. Neurological involvement occurs in up to 10% of patients with untreated syphilis. That is where we have to be very careful. Neurosyphilis should be considered in patients with signs of symptoms of neurological involvement at any stage of T. pallidum infections, or in all patients with latent or tertiary syphilis, although asymptomatic neurosyphilis is the most common presentation. Neurological involvement should be suspected in patients who previously have been treated with neurosyphilis patients who have not responded to treatment of primary, secondary or latent syphilis, and patients who have HIV infection or other conditions that compromise immune status. Lumbar puncture is required to establish the diagnosis of neurosyphilis, because if you examine CSF, you will have to get into a lumbar puncture, and the tests are done on the CSF. Signs and symptoms commonly seen in patients with neurosyphilis today. Cranial neuropathies, especially neurosensory loss, dementia, loss of reflexes, personality changes, papillary abnormalities, seizures, strokes, syphilitic eye disease, retinitis and uveitis. So all these are common symptoms of neurosyphilis. So we come to dark field microscopy, which is really ideal if you can perform in your lab. Dark field microscopy is the most specific technique for diagnosis or diagnosing syphilis with an active chancre or condylarma latum is present. However, its accuracy is limited by experience of the operator performing the test. The number of live treponemes in the lesion and the presence of non-pathogenic treponemes in oral and anal suspensions becomes diagnostic. In preparation for dark field microscopy, the lesion is cleaned and then abraded gently with gauze pad. So gently you have to abrade it. Once a serous exudate appears, it is collected on a glass slide and examined under the microscope, equipped with dark field condenser. I told you will need a special microscope for this. T. pallidum is identified by its characteristic corkscrew appearance. Given the inherent difficulties of dark field microscopy, negative examinations on 3 different days are necessary before a lesion may be considered negative for T. pallidum. So you have to repeat it on 3 days, and you have to take a look out for these little spirochetes that may be floating around in the lesion. Here we go. So this is what they look like. Put the compounds here. Alright? Then in this, the second one, you've got treponema pallidum in dark field microscopy. Very, very characteristic. Then you've got treponema pallidum fluorescence microscopy. So here you can stain the organism with your fluorides. Non-treponema tests, which we do in the lab very often. So you've got a reactive test, you've got a non-reactive test. You can see how smooth it is. And you've got the reactive test over here. So whenever you will have this reactive picture, you will have to go ahead and dilute the serum. Syphilitic infection leads to the production of non-specific antibodies that react with cardiolipin, that is your anticardiogen lecithin. This reaction is based on traditional non-treponemal tests such as the VDRL test and the rapid plasma reagent test RPR. With non-treponemal tests, false positive reactions can occur because of pregnancy, autoimmune disorders, and infections. In addition, these tests may show a prozone phenomenon in which large amounts of antibody block the antibody-antigen reaction, causing a false negative test in the undiluted sample. So you can have a false negative with prozone. So here we go. Let's take a look at the first algorithm. We've got non-treponemal tests, example RPR. So reactive, we've got treponema test. Non-reactive is negative for syphilis. If it is reactive, you've got 2 choices, reactive and you've got non-reactive. So you've got your treponema test, which is your fluorescent treponema antibody test. If it's reactive, that means yes, something is there, it's positive. So disadvantages, manual RPR and subjective interpretations become important. Screening method is non-specific and may lead to false positive results. Not suitable for high throughput laboratories. Potentially lower sensitivity of detecting early syphilis and latent diseases. So the algorithm either rules in or rules out the syphilis. And over here you can see what happens in the days present. In last okay. So you've got the weeks, and you can see how the FT antibodies are helpful. And then you've got a test called the TPHA, treponema pallidum heme agglutination inhibition test, which is much better. Continued qualitative non-treponemal tests are widely used for syphilis screening. However, the usefulness is limited by decreased sensitivity in early primary syphilis and during late syphilis, when 1 to 1/3 of untreated patients may be non-reactive. After adequate treatment of syphilis, non-treponemal tests eventually become non-reactive. However, even with sufficient treatment, patients sometimes have a persistent low-level positive non-treponemal test, referred to as serofast reaction. Titers are not interchangeable between different test types. Hence, the same non-treponemal test could be used as in follow-up evaluation. So once it's positive, it is better that a follow-up is obtained. So we go further. Nazneen, you admit? Nazneen's coming?
Yes.
Okay, Nazneen, you're in. Can you hear us? We've started. We have done, I think, what, 10, 15 slides already? So we have come to, yes, we have slide 2, we are on 15, correct? Non-treponemal specific tests. Treponemal specific tests detect antibodies to antigenic components of T pallidum. These tests are usually to confirm the diagnosis of syphilis in patients with reactive non-treponemal tests. However, the enzyme immunoassay EIA test for anti-treponemal IgG can also be used for screening. So IgG, as we know, is a titer that tells you there's past infection. Treponemal specific tests include the EIA for anti-treponemal IgG and the T pallidum hyperagglutination test, TPHA test, the microhemoglobin test with T pallidum antigen, the fluorescent treponemal antibody absorption test, FTA antibodies, and the enzyme-linked immunosorbent assays. All these tests are there that can be performed. So keep it in mind. Enzyme-linked immunoassays, looking out for IgGs, past infections. Then you got TPHA, which is done on a micro slide. The microhemoglobination test for T pallidum antigen, fluorescent treponemal antibody absorption test, and the enzyme-linked immunoassay sorbent assays are important. Okay. So the sensitivity of serological tests in untreated syphilis is given to you before. So you've got the VDRL test, percentage positive range was 78%, the secondary 100%, it can tell you, pick it up. Latent is about 95, and tertiary is 71. Then you have the rapid plasma reagent, which we use very routinely in our labs. Then you've got the fluorescent treponemal antibody absorption test. It's very good sensitivities. You've got treponemal agglutination, and you've got the enzyme immunoassay tests. All these can be used for diagnosis of syphilis, and they have fairly good values, and if they are positive, they have to be followed up. So treponemal tests have sensitivities and specificities equal to or higher than those of non-treponemal tests. However, treponemal specific tests are more difficult and expensive to perform. This limits the usefulness as screening tests. In addition, false positive tests can occur, especially when the fluorescent treponemal antibody test is used in patients with syphilis, with systematic lupus erythematosus or Lyme's disease. And I hope you remember SLE. Unlike non-treponemal tests, which show a decline of titers or become non-reactive with effective treatment, treponemal specific tests usually remain reactive for life. Therefore, treponemal specific test titers are not useful for assessing treatment efficiency. So here you have to go by trial and error and find out what is most consistent. Keep that in mind, because We don't want false positive, and the poor patient can get into trouble if you're reporting a false positive. Okay? You have a table coming up. Huh? Alright, so you've got other tests of importance. Direct fluorescent antibody tests for T. pallidum. Direct tests as T. pallidum in tissue sections. Nucleic acid amplification methods. Non-treponemal serological tests, and that is fairly specific if you can afford it. Serological tests, treponemal serological tests, fluorescent treponemal antibody absorption tests, and fluorescent treponemal antibody absorption double staining tests, EIA, in the Western blot. And that will be the final confirmation. But like I said, they're expensive and extremely sensitive. So you've got the manual and the automated. You've got a direct dark field or contrast microscopy or direct fluorescence antibody stains. Then you've got non-treponemal IgG and IgM against lipoidal cellular antigens. So there you've got the VDRL and the RPR in the manual. And then you've got the treponemal IgG or IgM against T. pallidum. There you've got a wide variety. In the manual tests, you've got treponemal pallidum absorption, fluorescent treponema absorption tests, and the automated, you've got immunoassay, CIA, and EIA tests. So they become quite specific. False positive and false negative serological reactions, so that's a caution. You can't have either. The phospholipid antibody detected by non-treponemal tests are not only produced in syphilis and other treponemal diseases, but also in response to a variety of conditions unrelated to syphilis. Therefore, false positive non-treponemal test reactions can have multiple causes. What are they? Let's see. The incidence is generally 1 to 2%. The rate of false positive during pregnancy is no greater than that seen in the general population, but is higher among intravenous drug users. Generally, up to 90% of false positive reactions have a titer of less than 1 in 8, and the reactive non-treponemal tests with titers less than 1 in 8 and subsequent non-reactive treponemal tests are considered to be biological false positive reactions. That's the reason why we limit ourselves to our reports. Anything above 1 in 4 is considered positive. Anything less than 1 in 4 we consider it as negative. Okay. Chronic false positive reactions persist for more than 6 months and are often associated with autoimmune disorders and chronic inflammatory conditions. False positive reactions can also occur with treponemal tests, but this is less common than with non-treponemal tests. Both types of tests can also yield false negative results due to the prozone phenomenon. Such false negatives occur in 1 to 2% of patients, especially in pregnant women and HIV patients. Serum of such patients should be tested at a 1 in 16 dilution. This, however, requires that the laboratory is given the relevant information from the patient's history and clinical diagnosis. So, the relation to HIV, especially if you have an HIV positive patients, it is important. And I've always stressed that when a patient comes to you, take the history. Take the history. I feel that 90% of patients do tell you. There are 10 who tell you very diplomatically, mind your business. But if you know the history, then you know what dilutions to go by. Okay. Evaluation of treatment efficacy. Definite criteria for treatment success or failure have not been established, and assessing response to treatment is often difficult. Also, treatment failure cannot be reliably distinguished from reinfection. Now that you have to be careful. That guy is cured and then again he goes and mingles with some other person and the reaction occurs again. Generally, the efficacy of therapy is monitored by remission of symptoms and a decline in antibody titer as measured by non-treponemal tests. Sequential antibody titers should be measured using the same test in the same laboratory. A post-treatment fall in titer confirms response to treatment, and a rise in titer indicates treatment failure or reinfection. Keep that in mind. Diagnosis of secondary syphilis. All serological tests for syphilis are expected to be positive in secondary syphilis. RPR, VDR titer in untreated cases are often more than 1 in 8 and 1 in 16. 1 in 8 in VDR and 1 in 16 in RPR. If a specific treponemal test is used for diagnosis and is found to be positive, use the VDR RPR test to determine disease activity and to monitor response to therapy. So you have a combination of two and you have to decide. So antimicrobial susceptibility testing. Antimicrobial susceptibility testing is technically difficult. T. pallidum strains are uniformly susceptible to penicillin and its derivatives, which are the preferred antimicrobial agents of the treatment of syphilis. Regardless, a number of methods have been used to determine the susceptibilities of representative strains. This service may be available through specialized laboratories and reference centers. I told you this. You have to look at it very, very carefully as to what you have and what you can afford and what the patient can afford. Early syphilis alternative treatments are here. You got procaine, penicillin G, 600,000 units IM intramuscular daily for 10 days. You got doxycycline, 100 mg. You got azithromycin, 2 grams. You got azithromycin, 500 milligrams, given for so many days. Erythromycin, 500 milligrams. You got ceftriaxone, 500 milligrams daily, and you got amoxicillin. So all these different regimes and strengths of antibiotics can also be given. It depends on the doctor, keep in mind. Which are the forms to cure syphilis? Previously it was mercury, but this treatment is more toxic than beneficial. Today syphilis is easily cured with antibiotics like penicillin. During primary and secondary phase, penicillin is also active in the last stages, although in that case should be the G sodium penicillin intravenously given. However, the treatment does not reverse any damage that the infection has already caused. So the damage will remain, but the infection will get into hand as quickly as possible. A cure of sorts. Quality control. It is critical to ensure the reliability of intra and inter-laboratory reproducibility results. This can be accomplished through a number of quality control measures that range from maintaining a good basic laboratory practice to use for standardized reagents, controls, and techniques, strict adherence to test procedures, and participation in recognized proficiency testing programs. The quality control program should be under active surveillance to facilitate prompt recognition and correction of any problems. A detailed description of general and specific quality control measurements pertaining to various staff is provided elsewhere. So there are certain norms that have to be established and you have to follow those norms of quality control. So here we've got what is quite good. The Alexis syphilis immunoassay, this is a Roche machine. One-step double sandwich assay. One-step double sandwich assay, 100% sensitive, 99.8% specific. The ideal test is, this is the ideal test now. detects total antibodies against T pallidum. The numbers are 15, 17, 47 the strains. Highly sensitive, cost effective, clear cut of between positive and negative. Result uses 10 microliters of serum. Testing time 18 minutes is very, very standard for all Alexis and Roche machines. Patterns of serological response. Serological tests remain the method of choice for diagnosing syphilis. 2 or 3 weeks after infection. IgM antibodies are usually detectable, followed by the appearance of IgG approximately 2 weeks later. Treponemal tests such as Alexis syphilis tests are utilized to detect the presence of anti-T pallidum specific antibodies in serum. In the reverse screening algorithm, the Alexis syphilis test can be used for screening, diagnosis and confirmation of the infection. Positivity of the treponemal tests can be observed 2 to 5 weeks after the initial infection and remains reactive for years, if not lifetime. So you have to be very careful because this test can be with you for a very, very long time. So now these are the different modules of Alexis 602 with the CV cutoffs, etc. You have the Imulite 1000 and you have the liaison, and it will tell you the specificity and the sensitivity of the assays. So with the comparison of inter-assay CVs, coefficient of variation, at the lowest concentration tested, source, package inserts, and this is, as you can see, it is quite sensitive. If you will use the machine, all the particulars are given to you. Okay, and I think that's the last slide. That's the end, guys. Any questions? Nazneen, what are you using? What are you guys using? Unmute. Can't hear you. No, tell us. I still can't hear you. Volume jara little high. No? Nazmi, we can't hear you. Can't hear you. We are okay up here. Your volume. We can't hear you. Roina, tell us a little bit. Bolo.
Actually, our company is promoting this and we're just having this kit which we give to the ministry. We are using the RPR.
RPR. I think that everybody uses.
Yeah, on this side. Yeah, that's what we are doing. Because we don't have many cases. I had been to the maternity hospitals here. So I came to know in a year maybe there might be 5 cases. That's there.
Yeah, because this is carbon particles which are coated on, and it gives you the antigen-like effect. And we are using the same thing here. Once it is positive, we give the titer. I think Nazneen, you were saying something? Nazneen? Can we hear you?
Now it is coming.
A little louder still? Can't hear at all. Meena, something coming back to you?
Yes.
DCA days? Parul?
Can you hear me, ma'am?
Yes, better,
Yeah.
better, better.
Yes. Yeah, we are doing, ma'am, RPR and TPHA, ma'am, hard methods.
Okay. So what do you think of TPHA?
Ma'am, actually, this Roche Cobas Alexis model is very good actually, where when we do IM methods also and we do CIA methods also, because it has got an integrated logic now in 2026 models. Because it's called reflex logic, means if we have got these tests on board, it will directly go and do the confirmatory test if this machine is device, the one that you showed in the PPT.
You're talking of the machine or you're talking of the TPHA? Because TPHA is a plate, right? At least what we used to do was a manual, it was a plate. I felt it was quite a bit of a sensitive, but you have to be very careful. You were careless with it and you'll get a false positive.
Yes, and then there is Atalica also, Atalica IM module also, there Beckman also is now launching these modules to be done on the machines. Full term.
Okay?
So we can do on those machines also.
But
Nowadays they
are you having a high percentage of these guys positive tests?
over here, yes, we are having, yes, because in this country we are having a lot of people coming from all over the world, and this is a tourist place, so we are having a lot of positives over here for many of the STDs. In fact, this country is known for STD panels. We have a lot of STD panels in PCR, and there are numerous kits. This is a market for all types of kits for STDs. 14, 28, whatever is the panel count, they will market, because this is a place for tourism.
Yeah, but hello, before somebody enters your country, isn't the VDRL done as an entry level? No?
No.
Okay.
It is done here as a part of. It is done here as a part of screening for residence visa, not for
Okay.
tourists.
रोहाना, what about you? कुवैत में क्या कर रहा है? Ro, can you hear me?
Same thing, ma'am. It's for the residents. Same thing, yes, ma'am. For residency, we do it,
Yeah. Okay.
but not for. We don't have tourism.
All right. Anybody else? I think there's some visas that require VDRL, right? Some visas require VDRL.
Yes. And also, it is a part of a year for premarital screen also. Here, the government now makes it compulsory, because the part of the population, they realized some years back, around 10 years back it has started, that premarital screening should be done. In that, they are screening for genetic diseases also, the G6PD also, thalassemia also, then they are all this STDs also detection. So the government makes it mandatory for these tests to be done before a Muslim boy or a Muslim Arab girl gets married. So
Okay.
for them it is compulsory.
That's good. Anybody else with views on this? Shubha?
Yeah. Should I tell last time Parul, good afternoon. Last time
No,
Parul
we'll come to that. I know you got it ready. But anything else you need to say about
I
syphilis
need
testing?
to say that the testing is very, very important. Especially, we should go in for enzyme immunoassay or chemiluminescence immunoassay, because that is the confirmatory test, because it gives us the current infection and the past infection. Past infection will remain positive for many years, because it will show that once upon a time you were positive for this. But immediately it is also very important, because if the patient is having the secondary phase where the patient has fever, rashes, so there the patient should be taken in for the present infection. And I think that I evaluate and I give importance to the chemiluminescence immunoassay, because if it gives a false negative, it is going to be very dangerous. As you rightly said, that it will go in for neurosyphilis. That is actually our neuro problems will set in. Neurological, it affects the central. Uh, can I tell Nazneen just to don't keep on moving her hand, please? Excuse me. So, neurosyphilis is very dangerous because it affects the central nervous system. Okay, and even it goes in for a cardiovascular problems. So, if you are fearing about these problems, and then you have also shown us the picture of the gummatous disease, then you have also told about actually this should be taken into consideration about the present infection and the past infection. It will be more important than the RPR test and the VDRL test. And as you told many things like dark field microscopy and all that, but I think that is the test, like IgM, the antibody test, and IgM and IgG.
Okay.
And you also said that quality control is very important, because if you are going to have some problem with your testing, the quality control will bring into picture that you are going wrong. Either your the sample has got a problem, or your reagent has got a problem. So the quality control testing is very important. And also you have said about the checking with the inter-laboratory testing. That is also very important, because something must have gone wrong with your reagent. Something must have gone with the collection of the sample. So it will immediately be brought into notice. So quality control is the need of the hour. Selection of the right test, especially the chemiluminescence immunoassay, ELIXIS, and all that, that is the need of the hour. And because it should not progress to the dangerous, deadly central nervous system infections and cardiovascular problems.
Okay, Shubha, then yeah, I think Parul sent give you a question, and I think you prepared something on it. So thank you.
Yes. She asked me, my question, if I am mistaken not, her question was, what is the calcitonin levels in a hypothyroidism? Hyperthyroidism, that is hypothyroidism, where T3, T4, TSH, T3, T4 are low, and hyperthyroidism, that T3, T4 are high. Then I said about the multiple myeloma, I said that there is a rise of calcium. Parul, was this the question that you had asked?
Yes, ma'am. It was that if in multiple myeloma, when calcium rises, calcitonin will be released to reduce the calcium levels.
Yes, so they actually use in multiple myeloma, calcitonin is considered as the modality, one kind of modality of treatment. They use nasal sprays of calcitonin in order to ease the pain, in order to lower down the values of calcium. So that is what is in multiple myeloma. In hypothyroidism, when Hashimoto's disease, where T3, T4 is low, we say that the calcitonin is released by the parafollicular C cells of the thyroid. So, in Hashimoto's disease, these parafollicular C cells are destroyed. So, the calcitonin level is low in T3, T4 levels low. Okay, so calcitonin will be low because of the destruction of the parafollicular C cells, and that is hypertrophy of the thyroid. In hyperthyroidism, there is hypertrophy of the thyroid. There is a hypertrophy of the thyroid, and in that case the parafollicular cells will release extra calcitonin, and there will be a rise in the levels of calcitonin. So in Hashimoto's disease there is destruction of the C cells, so the levels of calcitonin are low. In hyperthyroidism, the hypertrophy of the parafollicular cells, and so the levels of calcitonin will be high. And in multiple myeloma, what they do is they use the nasal spray as relief to the patient, so that the bone pain etc. will be little bit, they will give a relief to the patient. Not a complete treatment, no, it is just a kind of relief to the patient, because they have lot of bone pain etc., lot of back pain, lot of spinal pain. So it is used as one kind of treatment, other nasal spray to ease the pain.
No, ma'am, I didn't understand. In multiple myeloma, calcium increases, right?
Yeah.
So calcitonin in the body, the C
Yeah.
cells have to release the calcitonin, right?
Yeah.
So it does release calcitonin.
Yeah.
Yeah, that's all. That was what I was wondering. It
But
would release.
this calcitonin is released to decrease the calcium levels, right?
Yes, ma'am.
Yeah. So then, in what I got the information means it is in the knowledge group that calcitonin sprays are used to decrease the calcium level, because multiple myeloma patients will have a very high calcium. It is even to the range of 13 to 14 milligrams per day. But the
So that
reference
is the reason there's not enough calcitonin. Is that the reason they put the spray and they
Yes.
treat with
Yes.
calcitonin?
Yes.
But our body does release extra calcitonin at that time or no?
No, the calcitonin which is released due to the breakdown of bones, the release of calcium, and to when the calcium is released in a lot of amount, the calcitonin released, actually the body will not, but calcitonin spray in the form of medicine is given to the patient to release that calcium levels. There will be a subtle release of calcitonin, but actually a proper amount of calcitonin is given in the form of treatment, in the form of medication, in the form of nasal spray to lower the calcium. But the actual treatment is the steroids and then also the chemotherapy agents.
That's right, ma'am.
Yeah.
No,
Yeah.
my question was that our C cells of the thyroid, when calcium is increased in multiple myeloma because of bone destruction, will release extra calcitonin than normal. That is right.
Yeah.
Is that right? But it is not enough.
It is not.
It
Correct.
is not enough, and that is the reason
That's
we
correct.
use the spray.
Yes. Yes.
Oh,
Yes.
thank you, ma'am.
The release of calcitonin in the form of spray, it will be adding to the treatment, but that is not the treatment actually, because
Yeah.
patient has to be given a chemotherapy treatment, whatever are
Yeah,
the
that is for the cancer itself. But
yeah.
but for the calcium level to be controlled, you give the spray. That's what.
Yes. Yes.
Yeah.
Yes.
But
You can
Shub-
also go
Shubha,
on and find out.
you're talking of non-Hodgkin's lymphoma?
I'm talking about not about the lymphoma. I'm talking about non-Hodgkin's lymphoma. I have no knowledge. I will have to read again. But I'm talking about multiple myeloma.
Okay, all right.
That is the hyperproteinemia, immunoglobulinemia, especially the presence of, which is confirmed by the
Yeah,
presence
I got
of
it. I got it.
Yes. But today's presentation regarding syphilis is lovely, wonderful, and the proper staging is shown. Then you have also spoken about the treatment, where there is the procaine, penicillin G, and then you have also spoken about the erythromycin, azithromycin, and finally amoxicillin. That is also the treatment wise you have said. You have also spoken about the this the measurement, the immunoglobulin, how the measurement is done, and especially the enzyme immunoassay, the chemiluminescence immunoassay, I feel they should be the kind of diagnostic test, because they will give you whether it's a present infection, whether it was a past infection, and it will not give you any false positive or false negative. And you have spoken also wonderfully about the quality control, which has to be done. If your reagent is bad, or if your collection of the sample is not proper. So in that case, quality control is also very important, especially the inter-laboratory exchange also is very important. You get a confirmed diagnosis. Okay, since it will proceed further to dangerous neuromuscular diseases, central nervous system, and also the cardiovascular disease. So thank you very much.
Okay. Any other questions, guys? That was a very good explanation ma'am's given us. Meena,
Thank you, ma'am. Thank you,
Ramal,
ma'am.
Apna, Parizad, Roina, Nazneen, any questions? Then we'll say goodbye, and our what's the next presentation? It's quite interesting.
Ma'am, my sister wants to say hello to you.
Hi,
One, Vidila.
Hello, how are you?
Cystatin. Hello, how are you, ma'am?
Yeah, I'm fine. How are you?
Okay, we heard all about your knee problems.
Yeah. TKR was done. I was operated on January 2nd this year. Now I'm quite okay.
Good.
We will come one day to meet you, both of us.
Please come.
It should not
Very
be
welcome.
okay.
Very welcome.
Yes. Cystatin C, yes, I have published 2-3 papers on Cystatin C.
We've got Cystatin C and CRP.
Yeah,
It's a
so
CRP,
Cystatin-
CRP.
Cystatin C and CRP.
CRP. Alright, so we've got Cystatin C.
Cystatin C, I have presented,
Yeah.
I have published 2-3 papers also.
Okay, alright.
Myself and Dr. Janardhan Nimbolkar, who is a consultant now, who has become a consultant now in British Candy Hospital. So we have published 2-3 papers together.
Okay, that should be interesting. That should be interesting. Alright, guys, we shall see you next Thursday. Thank you for
Thank you, ma'am.
attending.
Thank you, Dr.
God bless.
Abha.
We'll see you. Ta-da.
Thank you.
Bye-bye.
Thank you, ma'am. Very good lecture. Thank you.
I'll get you money.